And now for our first presenter on the racism issues, we have Dr.Mireille Kanda, a retired pediatrician, past director of Health and Disability Services at the Head Start Bureau, past director of child protection at Children's Hospital in Washington, D.C., and past deputy director at the National Institutes of Health as director of the National Center on Minority and Health Disparities. Since 2016, she has served as senior advisor to the Dikembe Mutombo Foundation, where she assisted in the launching and management of the Biamba Marie Mutombo Hospital in Kinshasa. She is Haitian-born and holds degrees from American University, the George Washington University School of Medicine, and the Johns Hopkins University Bloomberg School of Public Health.
Hello, it's a pleasure to be with you today to discuss a subject which is very complex and that requires much more than the time that we have together. Our new reality is very different from what it was a year ago, from wearing our masks to having virtual meetings. A unique year indeed. Under the shadow of the pandemic of COVID-19, we are now looking at the consequences of the death of George Floyd and others and the reality of the Black Lives Matter movement. We realize that racism has a great impact on our lives and the way we treat each other. We want to be reminded that there are fundamental truths that are always there with us: our love for God and the commitment to love our neighbor as ourselves. This means not only our next door neighbor, but all the people with whom we come in contact on a daily basis. Yes, things are changing, and change is challenging and sometimes uncomfortable. It requires that we go beyond what we are used to. On the wind of change, 69% of Americans believe that racism is a big problem in America. Even the Webster Dictionary is expanding its definition of racism. We are understanding that racism is more than an individual failing, but rather a systemic construct built by society. We are looking more clearly at the issue of white supremacy, which presupposes that one group is superior to others and deserves to have advantages that the others should not have. Let's look at the definition of racism in Wikipedia. Racism in the United States has existed since the colonial era, and it involves laws, practices, and actions which discriminate against various groups or adversely impact them in other ways based on their race or ethnicity. Formal racial discrimination was largely banned in the mid-20th century, and over time, it became to be perceived as being socially and morally unacceptable. When we look at the intersection of racism and health, some things become very evident. What is clear is that racism has an impact on health and that it causes health disparities. Health disparities are not new. What is new is that they present a problem. The American government, through the Department of Health and Human Services, has recognized this problem and discussed it in a series of major reports, starting from the Heckler Report in 1985 all the way to Healthy People 2020, which has specific goals to address disparities. Health and healthcare are distinct but closely related, and they join in creating, with racism, the poor outcomes that we can see as health disparities. Health and healthcare disparities are differences in health and healthcare between groups that are closely linked with social, economic, and/or environmental disadvantage. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Race is not the only factor affecting disparities, but racism is a major cause of disparities. A major issue in understanding this universe is discrimination. What is discrimination? It's a socially structured action that is unfair or unjustified and harms individuals and groups. The impact of discrimination occurs at both structural, meaning societal level, and at an individual level, which means negative interactions with specific people, like salespeople or even fellow passengers on a bus who move away from you, or the taxi driver who ignores you to stop a few steps beyond you for a white person ahead of you. Discrimination is often measured by either everyday humiliations or major discriminatory events, like being denied a loan by a bank because of your race. As an example, a young black man is familiar with the look of alarm that may show on the face of a salesperson when he comes into a store, and how he may be followed around and repeatedly asked what he wants to buy. Discrimination may be invisible to people who are not subjected to it, but it is plain and very painful to its victims. Researchers have tried to understand the impact of racism and its relationship to health disparities. There are at least 3 big research models. The first one is the study of chronic and repeated stress that racism and discrimination cause. Chronic stress leading to chronic conditions like hypertension, diabetes, obesity, and inflammatory diseases. The second model is the model of social determinants of health. Health exists in the context of the broad environment in which we live. That includes access to good food, water, housing, the quality of schools, workplaces, neighborhoods, and the composition of social networks and relationships. The third model is the brain impact model. The impact of unrelenting discrimination on the brain affects self-regulation and leads to things like hypervigilance and negative coping behaviors like overeating, alcoholism, mental disorders, substance abuse, etc. These outcomes are often seen in populations that are oppressed. Let's look at some examples of issues that lead to health and healthcare disparities. Let's start with a lack of access to healthcare and healthcare facilities. This may be caused by financial constraints or by geographic location. Discrimination would be another example, and we have mentioned it before, but it also includes implicit bias. Implicit bias is a more subtle and sometimes unconscious reaction to a certain group of people. It means how you are treated by a provider of services, who may think that because you are for a different racial group, you cannot understand complicated instructions, and who does not even bother to give you a new type of medicine that works better than an old one. The next example is inferior care. It has been shown that discrimination leads to poor and inferior care. For example, a black woman with a serious abdominal pain problem may be ignored by racist caregivers and denied the pain medication that they would readily give to a white patient. All those examples show what can transpire and how poor outcomes are created. How do we prevent and access or address health disparities due to institutional and individual racism and discrimination? Unfortunately, we do not have enough time to do justice to that discussion right now. But let's start anyway. We have to begin with self-awareness, and we have to recognize our own biases, face them, and be open to them and address them. We have listed 7 steps forward. Let's go down our list. The first step is poverty eradication. This deals with the social determinants that we have mentioned earlier, the environmental, economic, and cultural determinants that accompany the social ones. The second step is improved access to healthcare services. And that's where things like transportation and health insurance coverage come in. The third step would be an increased concordance between patients and providers. When they speak the same language, when they are from the same community and they are culturally compatible, this leads to better communication, trust, and better compliance. Ultimately, better outcomes. Provider training on implicit and explicit bias helps, particularly if the providers and the patients are different or discordant. Improved quality of care. Provider training helps improve quality of care and better leads to positive responses to the specific needs of the patients and community. And now let's address community outreach. The education of patients and the community lead to lifestyle changes and better outcomes. The patients can self-advocate and be the best advocates for themselves. Finally, health workforce development. There is a great need for a more diverse group of providers as the country becomes more diverse. And this has multiple benefits that extend over time and across populations. As you can see, there is much to be discussed and to be accomplished. We have only scratched the surface. I thank you for your attention, and I look forward to continuing this conversation with you at another opportunity.